Okay, I am gonna set a timer because this does go kind of long sometimes. Oh, okay, perfect. Okay, so I'm just gonna talk about imaging of the pelvic floor. So we have a couple different modalities that we'll talk about today, but we'll get started. It's the big green one. Okay, so functional disorders of the pelvis, they are common. They happen in both male and female patients. But they are most commonly seen in older female patients. That's the majority of the imaging that we get at KU and in general as well are going to be older female patients. But other risk factors are going to be increased intra-abdominal pressure, such as from chronic constipation or obesity, which I think is one that's less commonly discussed. And then any prior radiation, prior surgery, trauma, history of smoking, multiparity, those kind of things. So the symptoms of pelvic floor dysfunction vary, but they can significantly negatively impact the quality of life for these patients. And this is one of the things that I think is not really discussed as a society, is that the people that actually exhibit these symptoms, they don't talk about it. And so you don't hear about it and you think it just kind of doesn't exist. But they're very common, and we get a lot of MR and fluoroscopic defecography examinations at our institution. So functional disorders of the pelvis, first and foremost, the physical examination is going to be key. So these urogynecologists and people who evaluate these patients that are coming in for symptoms are going to do a POP-Q score. They're going to do a bunch of questionnaires, and they're going to try and figure out what's going on without imaging. But our imaging is usually used to diagnose pathology that's not able to be detected by physical examination. So when they do their physical examination, if something is not fitting with their clinical symptoms and their, their overall story, then maybe imaging is going to be their next step. And then we also want to further help direct treatment and surgical approaches for these patients. So not everyone who goes and sees a urogynecologist and gets surgery or has treatment is going to get imaging. But overall, when we do imaging, the goal is to decrease the intervention failure rate. The currently available imaging options at KU that we do are fluoro and MRI. So we do both. Several institutions around the country don't do both. They just drop fluoro or do fluoro or MRI. And then some places will do ultrasound, which we're not going to talk about today. So like I said, the imaging and defecography that we do at KU and that are most widely utilized are going to be fluoro and MRI. But neither is considered the reference standard. You can use both, either or. And that's why one of the reasons that fluoro has not just dropped off of the map completely with the, the rise of MR defecography, because they both have their benefits and limitations. And so some of those are going to be, patient preference, whether they think they can actually be in an MRI scanner and appropriately do the examination. Provider preference, some of the people who treat or the physicians who treat these patients are more comfortable with fluoro or more comfortable with MRI prior to their surgery. So it may be provider preference in what they specifically want. But fluoro in general is more widely available in the community settings as opposed to MRI that may not be available everywhere and may be more widely available at larger academic institutions. Fluoro in general it can be better in posterior compartment predominant symptoms as well. But MRI evaluates the dynamic function of all of the compartments, and you can see all of the compartments. Okay, so I'm going to go through this technique pretty quick. So in fluoro, we get a scout, we have them drink contrast, and then we will pass by the small bowel. Then we instill the rectal contrast and move on from there. For at our institution, if it's a female patient and they are able to insert a contrast-soaked tampon that is soaked in some contrast, obviously, then we have them do that so that we have also that being able to be visualized. But we don't like put a Foley catheter in and opacify the urinary bladder to see anything like that. And then of note, these are performed upright on the fluoroscopy table in the commode in the lateral position, just like any physiologic, stool encounter that these patients have. So here's our images. So we will get a rest image, a squeeze or a Kegel maneuver, strain, evacuation, and post. Sometimes you can get an AP post if you're worried about some kind of cul-de-sac hernia that you can't see. But these are the images that we get on fluoroscopy. MR defecography, right? We don't put any contrast anywhere except for the ultrasound gel or the contrast and gel mixed into the rectum to simulate that the rectum is full so that they are able to defecate for the examination. But we don't have them drink anything. You know, we can obviously see the soft tissues of the pelvis really well without contrast. So the bladder, and then the cervix here and the vaginal canal, and then the rectum, and then all the small bowel, you can see very well without contrast. For these images, we typically will get at least one small field of view T2 weighted image axial through the pelvis so we can evaluate the pelvic floor musculature, and then our same rest, squeeze, strain, and defecation images. Of note, just these patients are supine in the scanner, so they are not defecating in the normal physiologic position. So our normal pelvic anatomy that you can see on fluoroscopy, you see the opacified small bowel, you see the rectum here, and you can see the anorectal junction just as, you know, where that puborectalis sling is going to contract. You can see the last sacrococcygeal joint here. You don't really see the pubic symphysis very well. There's too much superimposition of structures, and sometimes patient positioning is a little bit off, so you're not able to see that as well. Whereas on MRI, you can see the pubic symphysis well, you can see the last the last coccygeal joint, that anorectal junction, and the small bowel, and then uterus and vaginal canal and urinary bladder. So our normal pelvic floor anatomy on MRI, you're going to see it really well, right? You're going to be able to see the muscles and the soft tissues of the pelvis without contrast, you know, opacifying any of them. And so here is a female patient where you can see our levator ani muscular complex is composed of 3 muscles, but this is really the most important one for our, you know, for our examinations here is going to be the puborectalis sling, which is like now my shaky pointer of the U-shape sling that wraps around the anorectal junction and then inserts onto the pubic symphysis anteriorly. And so in the male patient, you can see that this is the, you know, the prosthetic apex in the urethra there. And our puborectalis sling is still this U-shaped structure that's going to be inserting anteriorly on the pubic symphysis. So whenever we look at these examinations, the first thing that is good to do is to evaluate whether the patient was actually able to perform the defecatory maneuvers that we needed. Was the patient able to expel any of the rectal contrast, or was that patient just unable to do the examination completely for whatever reason? And then you want to see, is the pelvis moving? So does everything move way too much, way too inferior, or does everything just not move? So those are kind of the 2 buckets that I put things in. Does it move way too much? Does it not move enough? And then I will start to look at our anorectal angles, which are extremely variable between people. So I might do it one way, everyone in this room might do it completely different, right? And what really matters is how it's actually moving, how the anorectal angles move with the different maneuvers. And so they should narrow when you do that squeeze maneuver, try and hold everything in, and then widen with defecation so you don't have any impediment for stool evacuating through that region. So again, the actual numbers are not as important as the actual changes that you're seeing in the pelvis with those maneuvers. So here's an example of fluoro and MRI in the same patient. You can see that the numbers vary, right? But they're all within normal limits. And you can see that they become more acute on both the fluoro and the MRI image when they're trying to hold that stool in and do that squeeze maneuver. But then on defecatory imaging, you can see that they become more horizontal and more obtuse so that there is no obstruction to rectal evacuation. So other pathologies that we see on imaging, so we look for pelvic floor muscle asymmetry or atrophy. We look for descending perineal syndrome or generalized pelvic floor relaxation and descent. Dysynergic defecation, and then all of our pelvic organ prolapses that we can see. So this is an example of pelvic floor, the pelvic floor musculature. So this is part of the levator ani muscular complex here in a normal patient. It's symmetric. There's no bulging of the, the vaginal canal or any of the other pelvic structures. It looks very normal. Whereas on this side, there is atrophy of this levator ani musculature compared to the other side, definitely abnormal. In this case, it's probably most likely going to be, childbirth trauma, episiotomy, things like that is going to be one of the most common reasons for that. Descending perineal syndrome, also known as pelvic floor laxity or relaxation. This is abnormal caudal migration of the anorectal junction. And so this is probably the most common thing that we see, right? There's so much movement in the pelvis, and these patients are having a lot of symptoms from too much descent of the pelvic floor with defecation or just in regular life, right? Jumping, running, doing any walking, sneezing, any of these things are going to be symptomatic in these patients. And so these are going to be our reference lines that we use. The pubococcygeal line goes from the inferior aspect of the pubic symphysis to the last coccygeal joint. And then we measure that M line from that posterior aspect of the anorectal junction perpendicular to the PCL line. And then you measure your levator hiatal length by completing the triangle. So this is an example of the same patient on fluoro and MRI. This patient had on fluoro, we can't really use the PCL very well. Sometimes you can draw it, sometimes you can't. For the most part, I don't even try to use it. I just find a fixed point on the image that I know is going to be the same between the rest and the defecation image. And so I picked a little portion of the commode here, measure where the anorectal junction is at rest, and then measure where the anorectal junction is at defecation. And so this patient had about 3 centimeters of descent, being abnormal descent of the anorectal junction. On MRI, we use the PCL line and the M line. So that M line is going to be your inferior descent of that anorectal junction. And so in this case, this female patient didn't have as much descent on MRI, which is pretty common because it's supine. But she did have some descent demonstrated on her MRI as well. Dysenergic defecation is the other kind of bucket that I put our patients into. So if things don't move, the patient is unable to defecate, they they have a difficulty even evacuating any of the contrast during the examination. I kind of put it in this frozen pelvis kind of pathology. So it can be from a combination of things, but you in general cannot coordinate the muscles of the abdominal wall to contract and the pelvic muscles to relax to actually allow for the normal physiologic passage of stool. Most commonly, we're going to see that the patient's unable to defecate during the examination, or there's prolonged initiation of that anorectal opening. So I feel like this is the most common thing that I see with dysenergic defecation at our institution. But other things you look for are going to be persistent impression of the puborectalis or contraction, paradoxical contraction of the puborectalis when they're trying to evacuate. And then you can also look at the anorectal angles. If they don't open adequately, they stay the same or they become more acute with attempts at defecation, then you're going to be thinking more that they can't coordinate all those muscles to adequately expel the contents that they need to. So this is an example on fluoro. So you can see on this squeeze image, this is going to be the impression that you get from the puborectalis sling. When you do that Kegel maneuver, you should see that anorectal junction lift up and anterior. And on the attempts at defecation, you can still see that there's impression of that musculature there compared to the at-rest image. And this patient was unable to defecate for this examination. On the MRI that I don't remember if she had it before or after, but she had also had an MRI, and you can see that her squeeze maneuver does well, and you can see the impression of the puborectalis sling here. But then on evacuation, you can still see the impression of that puborectalis there. So that pelvic musculature in that sling is unable to relax adequately to allow for the normal passage of stool. So I'll go through these quick. A cystocele is just inferior descent of the urinary bladder below the PCL. So we don't evaluate this well on fluoro because we don't opacify the urinary bladder at our institution. But so when you get inferior descent of the inferior aspect of the bladder below the PCL, that's when you're going to call your cystoceles. Urethral hypermobility is another one. This is important because it can help direct surgical repair. So you'll do a pubocervical sling procedure as well as whatever other kind of pelvic floor surgeries this patient may need. On fluoro, you can sometimes infer this based on the location of the contrast-soaked tampon within the vaginal canal. If you have inferior displacement down with defecation, such as this example, and then you see it become more horizontal, you could infer that there might be some cystocele or urethral hypermobility on fluoro. But on MRI, you can see it really well, where it's vertical here at rest, and then it's nearly horizontal. It's just really sliding under that pubic symphysis, and everything's going too far and out because there's not enough room for all those pelvic structures going through that fixed area. So middle compartment, so this isn't going to be used in a male patient. I will usually just put, not applicable or something in my male patient defecography examinations. But this is just inferior descent of the vaginal apex if they've had a hysterectomy, or of the inferior aspect of the cervix if they've not had a hysterectomy. So in this patient, you can see on fluoro, though, there is inferior descent of the tampon within the vaginal canal here. And you can see the concurrent MRI where the vaginal apex descended 2.3 centimeters below the PCL. So this is going to be mild vaginal apical prolapse. Anterior rectoceles, we see these all the time. I'm sure if you read defecographies, you see them all the time. They are often asymptomatic or clinically insignificant if they're less than 2 centimeters. But our radiology, like our core paper that we use, calls them small if they're 0 to 2 centimeters. So I kind of keep that in mind when I'm calling something like 1 to 1.1 or 1.7 or something. I will say that this may be clinically insignificant given small size. But this is when you get anterior bulging of the rectal wall with straining and defecation. So this is an example on fluoro, which you can see really well that there's bulging of this anorectal wall here. And if you just draw the expected area of the anterior anorectal wall and measure the AP dimension, that's where you're going to get your quote unquote size of the anterior rectocele. This is the same patient's MRI. So you can see that there is some bulging. She's got, some other stuff going on with pelvic floor relaxation, but there's still some bulging of that anorectal wall. So she does have an anterior rectocele on MRI as well. Rectal intussusception and prolapse. These ones, I feel like I don't see as often. You can see them on both fluoro and MRI. But the important thing on this is that rectal prolapse is not just inferior descent of the anorectal junction. Rectal prolapse is when you get rectal intussusception going all the way through the anal orifice and out to the outer world where you don't want it. And so intussusception, when it's just mild, you just get protrusion of the wall into the lumen of the rectum, or you can get into the lumen of the anal canal. This can cause significant symptoms and is important to talk about if you see, because it can direct the surgeons to kind of, pexy that portion of the rectum or do some other surgical techniques. But the full extent may be underestimated if you don't have complete rectal emptying. So these patients that are unable to evacuate most of the contrast, I usually will say not present, but you can't evaluate it very well because we don't have enough emptying of that rectum to actually see if there's rectal mucosa protrusion into the lumen. So this is an example on fluoro where you can see that there's invagination caused by this nice interocele, but there's invagination of the rectal wall into the lumen of the rectum. So this is a intrarectal intussusception. And this is an example of an intraanal intussusception on MRI where you can see that here is kind of going to be our area that starts to protrude inward as they continue to attempt to defecate. And you can see it's kind of hard to see, but it ends up going slightly into the anal canal. So this is going to be an intraanal intussusception. Cul-de-sac hernias, so you can have them in 3 different flavors. They can contain peritoneal fat, they can contain small bowel, they can contain sigmoid colon. These are very rare in male patients, but I have at least seen one male patient that has had a cul-de-sac hernia. Of note, hysterectomy can increase the likelihood of having an interocele, so keep that in mind if you have a patient who has a hysterectomy or you're looking at these defecography examinations, and keep that in the back of your mind and have a high suspicion if they're getting imaged. So on this example, you can see there's on fluoro, you can see that there's widening of the space between the contrast soaked tampon and the opacified portion of the rectum here. And there's a little bit of gas density here. So there's no space here, and then there's a lot of space here, and you get those gas densities. So on fluoro, you can't see exactly what it is that's down there, but you would expect that the small bowel is opacified here. So this is probably going to be some portion of the sigmoid colon that's herniating downward more than it needs to. Oh. And this is the MRI showing the sigmoid colon hernia down here, well below the PCL line. Okay, benefits of the exam. So fluoroscopy is well established, it's quick, more widely available, and it may more closely match clinical symptoms and severity of pelvic floor dysfunction given that it utilizes gravity. MRI, you have superior anatomic detail. You can see the complex interactions of all the compartments together, but it is performed supine, so you may underestimate some portions or some pathologies of the female pelvis. And again, no single imaging examination is considered the reference standard. Okay, I promise I'm almost done. So when do you recommend a fluoro examination rather than an MRI? So typically it's done if the clinical symptoms don't match the severity of findings on MRI. If some things just aren't like being able to be put together by the urogynecologist and they can't quite figure out exactly why the patient's having the clinical symptoms and maybe the MRI is not showing those things, then a fluoroscopic examination may better evaluate some pathologies that aren't being seen, such as an interstitial, just because you have that gravity. And MRI may underestimate the extent and presence of an interstitial. And then when to recommend an MRI defecography? Again, this patient had fecal incontinence and could not keep the rectal contrast during the examination. They you put the rectal contrast in, they walk over to the commode and then it's gone. And so in this case, this patient may benefit from an MR defecography because then there's not gravity and it won't, the contrast won't be expelled before you're able to do your maneuvers in your examination. Okay, then that's it. Thank you.
Thank you, Christine. So I have to say is with fluoroscopy being close to my heart, so it was really great. So to see a lecture featuring a lot of fluoro images, thank you. So great lecture. So our next lecturer is Dr. Rex Parker, who is also a member of the Body Imaging Division at KU, and he's going to be lecturing on MR of the acute abdomen.
All right, thank you, Kirk. We'll try to go through this pretty quick since we're a couple minutes behind. For some reason, it's moving here, but not up there. It's not advancing. All right. Still, there we go. We'll skip the goals here. So the first question is, MRI in pregnancy, is it safe? And here I say probably, but the answer is yes. So there's never been any study that's shown any deleterious effect or teratogenic effect to doing an MRI in pregnancy. So if we're worried about doing an MRI in pregnancy, first trimester, second trimester, anytime, the answer is it's probably safe and we should just do it if there's a clinical indication that warrants it, right? That's the important question. So this is kind of a basic protocol for it. So we're going to do T2 single shot fast spin echo sequences in all three planes. Sagittals are important when you're looking for the appendix at times. We're going to do balanced steady state free precession images. So Fiesta, TrueFist, depending on your vendor. I like to do these in axial and coronal, but just one plane is also okay. You can do in and out of phase imaging. You could potentially leave that out, but I'll show you some benefits to this as we go through. A fat suppressed T2 weighted sequence is valuable for looking for inflammation. And I think this last one, this axial T1 fat spoiled gradient echo or fast spoiled gradient echo with fat suppression is an incredibly important sequence. And I'll show you examples of why that is as we go through. So the name of this talk was Tips for Success. So I'm going to go through and just kind of give a few tips, and they're usually going to be outlined in red. So aortal cable compression and respiratory motion are things that you deal with MRI in pregnant women, especially as they become larger later in pregnancy. It's difficult for them to lay supine. And so sometimes just putting a little wedge beneath them and tilting them up to the side can let them breathe a lot easier and like prevent these motion artifacts like we see here kind of propagating through the image. So this is respiratory motion. I love T2 weighted single shot fast-bend echo sequences in these. So the physics of this is kind of difficult to explain in a short period of time, but basically each image is obtained with one excitation pulse in less than a second. And so although there may be some motion between images, there's relatively little motion within the image itself. And so this is really a mainstay of abdominal MR, and I think it's really important for these pregnant patients as well. The downside theoretically is that these sequences have a lot of 180-degree excitation pulses, which theoretically lead to increased energy deposition into the patient, increased SAR. But I think it's, you know, the value of these makes it so that you should not worry about that, right? Like if you're going to image a pregnant patient, let's do the best possible study and let's get an answer, right? And so don't worry about that. This was something that was kind of interesting to me when I first started reading these on call, is that fat stranding on T2 weighted images that aren't fat suppressed is actually hypointense. And so you would kind of think that it would be edematous, it would be T2 bright, but without fat suppression, it's not. And so it's going to show like this T2 hypointensity. And so this is a woman with appendicitis. Appendix is dilated, and we can see that the stranding and the fat surrounding it is actually hypo-intense on these not fat suppressed images. The other thing that can be useful this is if you're using in and out of phase, the opposed phase, you'll have a lot of that India ink artifact from that kind of mixture of water and fat. And so that's another way that you can identify fat stranding on MR. But just kind of be aware that it's not always going to look bright, right? It might be kind of T2 hypointense like it is in this case. So having a fat suppressed sequence, though, can really kind of help you identify these areas of inflammation. And so here's same patient, acute appendicitis, you know, thick wall, dilated appendix. There's some T2 hypointensity in the fat on the non-fat suppressed image. And I think you can really kind of see the bright T2 signal on the fat suppressed image here as the corollary. So having both can be complementary, and this can make it easier. But I think if you're doing these types of studies on a routine basis, you should kind of attune your eye to be able to identify it on the non-fat suppressed images as well. If you can't find the appendix, my theory is don't worry about it. If you don't find the appendix and there's no inflammation in the right lower quadrant, the patient does not have appendicitis. And there's actually good evidence to support that. Most of it is CT based, I will admit, not MR. But if I don't find the appendix and there's not an inflammatory process going on in the right lower quadrant, I say the study's negative. So identifying the normal appendix is important, right? That can help you increase your confidence. Sometimes blooming on gradient echo images can be advantageous, right? So if normal appendix probably has gas within it. And so we would expect it on gradient echo images to have blooming artifact. And so here's a nice example of that. So this is a T2 weighted single shot fast-bend echo sequence up here. We see this tubular structure in the right lower quadrant arising from the cecum. And this is the same patient, and this is our Fiesta or balanced steady state free precession sequence. And we can see that that structure looks quite a bit larger, right? And that's the blooming artifact because this is a normal appendix with gas within it. The same sequences, the Fiesta or balanced steady state free precession sequences, can also help us differentiate a normal appendix from dilated periuterine vein. So when we're looking for a normal appendix, we're looking for a tubular structure in the right lower quadrant. And unfortunately, there are these confounders that pregnant women have tons of dilated veins in the periuterine region in the right lower quadrant, right? So BSSFP sequences, though, have bright blood. And so vessels will appear bright, whereas a gas-filled appendix would theoretically show blooming artifact. And so I find this very helpful. And so this is a patient where we can see there's a tubular structure here in the right lower quadrant. Is this the appendix? Is this a vein, right? I'm not sure. But if we look at the steady state free precession sequences, we can see that there's increased signal within that, which shows that that's bright blood. And I know that that's a vein and not the appendix. So these can be very helpful sequences in trying to differentiate a normal appendix from dilated veins. The same sequences are also helpful because blooming can aid in identifying appendiculus and renal calculi. So this is a patient with acute appendicitis. We see a dilated appendix, some periappendiceal vat stranding. On our out of phase and in a post phase gradient echo sequence, we can see something at the base of the appendix. On our in phase, where we have a longer TE, which will amplify the blooming artifact, we can see that that becomes more T2 hypointense and can help us identify that as an appendiculus at the base of the appendix. Renal calculi, same thing. So this is a woman with hydronephrosis on the right, some hydroureter. When we go down and we look at the pelvis and the coronal plane here, we can see that there's this area of blooming at the region of the ureteral vesicle junction. So this is a renal calculus, which was causing hydronephrosis. When thinking about hydronephrosis, though, it's important to recognize that it can be physiologic in pregnancy. Typically right-sided. And the way that you kind of differentiate it from the pathologic process is it tends to be tapered to the level of the sacral promontory. So this is pretty pronounced hydronephrosis, moderate to severe, right? We can see hydroureter extending from it. But if we follow this ureter down, we can see that it narrows at the level of the sacral promontory from compression from the enlarged uterus. And there was no other pathologic process going on. And so this is hydronephrosis of pregnancy. The patients actually don't have abnormal renal function. It varies based on position. They're prone for these examinations. And so it's important to recognize that this can be an expected finding when you're interpreting these studies. Next tip, fat-suppressed T1 weighted gradient echo images make identifying blood products easier. So this was a patient with a ruptured ectopic pregnancy. And I would argue that on this T2 weighted sequence here, that identifying blood products in the cul-de-sac is relatively difficult. The signal intensity is very similar to the subcutaneous fat, right? And it would be totally reasonable to interpret this as just normal fat. But if we look at the T1 weighted fat suppressed image, we can see that that signal intensity is bright, right? If that was fat, that should be dark. And so these sequences make it exponentially easier to be able to identify blood products in the pelvis. I think it'd be very easy to miss this if you didn't have the fat suppressed T1 weighted sequence. Some other examples. So this is a patient with hemorrhage in the cul-de-sac, right? And on T1 weighted sequences, I like to use internal references all the time in MR. The signal intensity of the fluid should be similar to the bladder, right? So this is a patient that just has normal free fluid, physiologic, right? And so it's similar to the urinary bladder. And this is a patient with blood, and it's different. Sometimes blood is really bright on these sequences, which is awesome. It makes things really easy. So this is a patient with a subchorionic hemorrhage, and you can see how bright that signal intensity is on this fat suppressed T1 weighted image. My next step is don't assume the pregnancy is intrauterine. So at a prior institution where I worked, the ER did lots of their ultrasounds themselves, and they would document intrauterine pregnancies, and they would send patients for these pregnant appendicitis MRs. And we had at least 20 or 30 ectopic pregnancies identified in MR afterwards. So think that ectopic pregnancy is a possibility in this patient population. So these are some findings of ectopic pregnancy on MR. First off, lack of an intrauterine gestational sac, right? Isolated hemoperitoneum without another cause, a tubal mass, corneal or interstitial mass, and hematosalpinx. So this is a patient that was presumed to have an intrauterine pregnancy, got an MR to look for appendicitis, and we can see that there's this kind of irregular cystic tubal mass, and this happened to be an ectopic pregnancy implanted into the fallopian tube. Some other examples, this is a patient where we see isolated hemoperitoneum, so some blood in the cul-de-sac, which is easiest to see on those T1 weighted fat suppressed gradient echo sequences, and we can see that there's not a pregnancy within the uterine canal, and so ectopic pregnancy. Another case, isolated hematosalpinx. So we didn't find a pregnancy within the canal, and there's this cystic dilated tubal mass in the pelvis that has intrinsic T1 hyperintensity on these fat suppressed T1 weighted images. And this is diagnostic of ectopic pregnancy. So this is a corneal ectopic. So these are kind of scary. So these are pregnancies that actually are in the uterus, but they're on the margin of the canal. And so instead of being implanted here in the uterine body where they should be, they're kind of on the fundal or corneal margin. The reason that these are worrisome is that the pregnancy can actually be carried a little bit further than it can otherwise with ectopic pregnancies. So you can see this is actually, I think this was a 20-week pregnancy where it grew. We get really markedly overlying myometrial thinning. And so when these rupture, these tend to have really severe complications. So if you do see a pregnancy, in addition to just recognizing it, think about the location of it. So sometimes you can have these ectopics that are in an abnormal location within the uterus itself, in addition to being outside of the uterus. My next tip is don't forget to look at the placenta. So the normal placenta should be relatively homogeneous in signal intensity, as we see here. And the uterus has kind of this Oreo cookie type appearance, I like to say. So it should be T2 dark on the inner margin, kind of T2 intermediate or high intensity in the middle, and then T2 dark on the outside. And the inner margin is really going to be the important one to kind of identify some abnormal placental pathology. It is normal to have some dilated veins in the subplacental region, so don't get worried about that. And it is okay to have some thin T2 hypointense bands running through the placenta itself. So this is an example of placenta previa on MR. So gravid uterus, and we can see that the placenta, although looks normal, right? Normal, homogeneous, it completely overlies the cervical os. So this should be one of the pathologies that you're looking for. Previa can be either total or marginal. Marginal previas tend to resolve as you go further in pregnancy, where the total ones tend to persist. And it's important to mention this because it changes management. Most patients with a placenta previa will end up getting a cesarean section. Placenta accreta is something to think about. So this is a term that describes abnormal placentation wherein the chorionic villi actually invade into the myometrium of the uterus. Accreta means that the villi attach to the myometrium, but there's not any significant muscular invasion. Increta is the villi partially invade into the myometrium. And percreta is the worst component of this. And this is when they invade through the entire uterine serosa and potentially cause hemoperitoneum. So what are going to be some findings that we're going to look for in these? One is just going to be loss of that normal T2 hypointense inner myometrial later, right? That we just talked about. You might see a focal uterine bulge. You might see heterogeneous placental signal intensity. Remember, we talked about the placenta should have relatively homogeneous signal. You might see dark, thick intraplacental bands. So thin bands are okay. If you see thick ones, you should be worried. And then in worst cases, you might see frank extension of the placental tissue through the uterus. So this is an example of accreta, where we have a focal uterine bulge, right? So the uterine contour is not smooth. And we can see that we have some of these dark intraplacental bands too. And these can be really difficult. I'll tell you, I struggle with these cases a lot. And diff them sometimes, right? Like I'm not sure. But these bands should make you suspicious, and any abnormal focal uterine contour should make you suspicious. Placenta percreta, so this is a little bit more severe, same pathology spectrum. And you might see frank extension of the placental tissue through the uterine wall. And so we have this focal bulge here. It's not the best image, unfortunately, or it's not projecting the best, but this really heterogeneous placental tissue is actually extending beyond the uterine wall. And the other thing that can be a tip off in this particular case is this patient has an umbilical hernia, and we can see that there's heterogeneous T2 signal within that hernia that actually is hemoperitoneum. The last tip is to think of outside of the appendix. So I tell our residents all this time, right? Patients that have abdominal pain in pregnancy can have complications from the pregnancy. They can have appendicitis, but they can also get any other pathology that anybody else can at the same rate as the same patient population, right? And so it's important that we think about other things when we're reading these particular studies. So this was a patient that presented with abdominal pain and pregnancy. You could see the gravid uterus. They had an umbilical hernia where we can see that there are small bowel loops extending into, which resulted in dilatation of small bowel loops and small bowel obstruction. So this is an SBO secondary to an umbilical hernia in a patient with presumed appendicitis and pregnancy. This is a patient with acute cholecystitis. So they have a dilated gallbladder with pericholecystic stranding and fluid, right? So just like you would explain it on CT or any other imaging modality, ultrasound, it will look the same on MR. This was a patient that they were actually suspecting choledocholithiasis, so we added an MRCP sequence in, and we can see that we have some mild biliary ductal dilatation. Here's the baby down here on MRCP, which is kind of interesting. And on the balanced steady state free precession images, we can see we have some blooming artifact in a small stone within the distal common bile duct. This is a patient that had presumed appendicitis and had diffuse colitis and was ultimately diagnosed with ulcerative colitis. So we can see that there's mural thickening of the colonic wall, some mural stratification, and some pericolonic inflammatory stranding, all consistent with acute colitis. This is a patient that was presumed appendicitis and had acute diverticulitis. So big sigmoid colonic diverticulum, a lot of inflammatory stranding in the pericolonic fat. And so acute diverticulitis in a pregnant woman with presumed appendicitis. This was a woman who came in and had a bunch of fibroids in her uterus, and some of them had undergone acute degeneration. So I don't have the comparison here, but she had had an MR before her pregnancy as part of her workup for trying to get pregnant. And all of the fibroids at that point were T1 hypo-intense or iso-intense. And several of them during the course of the pregnancy degenerated and had hemorrhage within them. And so here we can see that these fibroids demonstrate T1 hyperintensity consistent with hemorrhage. And incidentally, she also had this small subchorionic hemorrhage. But this can be painful and can be another reason why women can present with abdominal pain during pregnancy. This is one of my favorite cases, just because I think the imaging is really cool. Pregnant patient came in with right lower quadrant pain, has this big adnexal cystic mass, has kind of a hemorrhage layer within it, peripherally displaced follicles. So if you were to like talk to your residents and kind of describe an ectopic pregnancy, this would be exactly how you would describe it. And it turns out that this is, or not ectopic pregnancy, ovarian torsion. And this turns out to be ovarian torsion on MR. If you were to scroll through these sagittal images in real time, you'd actually see kind of a twist of the pedicle too. And so big ovary, think ovarian torsion, especially if you have fluid levels within it and some peripherally displaced follicles like we did in this case. So conclusion, MR can be performed safely and quickly in the pregnant patient with acute abdominal pain. Our single shot fast-bend echo sequences are going to be the mainstay of the protocol. Look for blooming artifact on the gradient echo sequences to help you identify the normal appendix or certain pathologies. The balanced steady state free precession sequences, if you include them, can help you differentiate the normal appendix from blood within dilated periuterine veins. I think you have to have fat suppressed T1 weighted sequences to identify hemorrhage. Don't assume the pregnancy is intrauterine. Don't forget to look at the placenta and think about other pathologic processes besides appendicitis when you're interpreting these studies. And that's it. Thanks.
Thank you, Rex. So couldn't help but think a little bit there about the scene from Roadhouse with the 3 rules. So I like to be nice, expect the unexpected, and be nice. So, well, we are the brave few that have made it all the way to the end of the conference. So I want to thank you one last time for coming to the conference. I want to thank the speakers that participated. Yeah, so absolutely could not do it without you folks, and I really appreciate your efforts. A lot of good talks, good information that we've covered. So to our folks that that are participating, our attendees. So it's good to have alumni and familiar faces come back and things like that. So look forward to hopefully seeing you folks in future years. So folk, I should say. Here we are to our last talk, and there's two names up there because I did not write this lecture. So it was Dr. Krishna Kumar who wrote this lecture and was planning on attending and giving this lecture. But as life would have it, he and his wife had their first child. So this past Friday. So that's the director for the course. I said that's pretty good. It's a pretty good one for being able to be excused. So a little bit different in approaches and how we would go about making our lectures, so that I find myself kind of looking at your lecture, Ryan. So more like Ryan, I usually just have a few bullet points and not a lot of text. And I find that other folks are kind of more of what I would describe as like the wall of text type of PowerPoint. So Krishna is more on that that vein of doing PowerPoints. So I will do my best to try and do justice. So, but anyways, that being said, so enough of a too lengthy introduction. We're going to talk about complications of acute cholecystitis and cholecystectomy. So we break down into things that could potentially go wrong in addition to just having acute cholecystitis. So that we could have acute cholecystitis if it goes undiagnosed or untreated for a prolonged period of time, can develop a gangrenous cholecystitis. Also, in certain patient populations, we need to be concerned about a more serious form of acute cholecystitis, that being emphysematous cholecystitis. And again, if it's something that is not treated at an appropriate time interval, also, or people that are dealing with kind of acute on chronic or multiple episodes of acute cholecystitis, that they can develop fistulae. So most common that we would encounter, we're going to be cholecystoenteric fistulae, but also there are less common manifestations. We can run into cholecystocutaneous fistulae. And then there can be vascular complications that occur with acute cholecystitis, with developing pseudoaneurysm of the cystic artery and portal vein thrombus. And we'll go ahead and look at some of those. And we're going to do this by looking at a series of cases. So case one is a 62-year-old with severe abdominal pain, fever, elevated white blood cell count. So we have long and short axis images of the gallbladder. We can see that we have hyperechoic material laying within the gallbladder lumen. So it's going to be sludge and stones. We can see that there's gallbladder wall thickening. We can also see what the yellow arrow is pointing to, that there's not only thickening, but there's also regularity of the mucosal lining of the gallbladder. So here we already strongly suspect that this patient has acute cholecystitis. They went on, oh, I'm sorry, I have a cine sequence showing. So a patient went on to have a contrast-enhanced CT scan. So here of axial and coronal images, so demonstrating thickening and of the gallbladder wall, the laying hyperdense material. What's of interest is as we're looking at this thickened wall, and we see that there's also hyperemia of the inner mucosal lining of the gallbladder, as we kind of trace that up to the fundus of the gallbladder. So we notice that we have this defect, and we have this area of hypoperfusion. So within the wall of the gallbladder. So this is going to be an ischemic portion of the gallbladder wall. That focal defect is corresponding to an area of gangrenous cholecystitis. So if patients are not treated in a timely fashion with acute cholecystitis, this can be a complication occurring up to 30%. And we're going to expect to see this more in patients with underlying diabetes and cardiovascular disease. And what we want to focus on is that on CT or on ultrasound, if we can demonstrate that we have that wall thickening and irregularity, but with that focal defect, so focal transmural defect. So on the CT, where we have an area that's ischemic, it's non-enhancing, and even can potentially progress to where we actually have physical, a physical defect, partial, or even, some it could be full thickness defect and perforation that would occur. But it's the focal transmural defect that and either enhancement or physical integrity that's going to tip us off about gangrenous cholecystitis. Our second case is a 71-year-old with a history of coronary artery disease, type 2 diabetes, presents the emergency department with generalized abdominal pain, on and off for 5 days. So again, here we're showing this is where kind of a delay in treatment. So they attempted non-operative management, assuming that the patient had with acute biliary colic, and imaging was obtained. So here we have grayscale and color Doppler imaging. So we could see the yellow arrow is pointing to the hyperemia that's associated with the wall of the gallbladder. So we have our layering debris, so within the gallbladder lumen. And then as we look at the grayscale image down in the bottom right corner, so we can see that we have, so this area of focal hypercoic focus here and the fundus of the gallbladder, although it doesn't project quite as well as it looks on my confidence monitor, but we also have, so the dirty shadowing that's associated with that. And I think, let me show here, yeah, so in the cine sequence is a nice job. We can see the multiple echogenic foci within the non-dependent gallbladder wall. And an example there, the dirty shadowing associated with it. So this is a patient, I'm sorry, patient went on to have a non-contrast CT, so we can see the layering calculi. But the important things to point out in making this diagnosis is going to be the wall, the gas within the wall of the gallbladder. And then sometimes we can see associated with that, that can also progress and have associated pneumobilia. So then we see there with the yellow line. So this is emphysematous cholecystitis. So this is going to be, very much a companion to when we see emphysematous cystitis. So it's going to be the same type of patients. We're going to see this in patients with a history of diabetes. This is a very severe, life-threatening diagnosis. These patients can quickly become very septic from this. And so the key for making the diagnosis is going to be demonstrating gas within the wall. So whether with ultrasound being the increased echogenicity with the dirty shadowing that is associated with gas, and that could be plus or minus with pneumobilia. Case 3, we have a 65-year-old, history of chronic cholecystitis presenting to the emergency department with acute on chronic abdominal pain and a palpable right-sided abdominal mass. So this is not a subtle case, but we have a contrast-enhanced CT scan. So we have sagittal and coronal reconstructions. And we can see that obviously we have multiple stones within the contracted gallbladder here in the right upper quadrant. And then we see in the overlying subcutaneous tissues extending through the abdominal wall musculature, we have this peripherally enhancing fluid collection consistent with an abscess that we can trace all the way back to the gallbladder. And we notice here that we could see that we have a stone sitting within this fluid collection. So pretty rare to have this happen, because most of the fistulae that are going to occur with acute cholecystitis will typically be contained within the abdominal cavity with a cholecystic, cholecystic, cholecystoenteric, it's so hard for me to say, fistulae, or cholecystocolic fistulae to the hepatic flexure. So as an aside, so I saw that Casey had you with the cholecystocolic fistula last week, Ryan. That was really neat. It was a really neat case. So that when you have this with the cholecystocutaneous fistula, of course, what we're looking for is migration of one of the gallstones into the fluid collection. It will typically be the tip-off for us that we know that there is fistulous communication. And then when we have the cholecystoenteric, cholecystocolic, of course, then we're looking for the same thing, where we look for stones that are in the wrong place that have migrated into the bowel, and that can be associated with associated with pneumobilia. So pneumobilia without a history of instrumentation or prior sphincterotomy should be a tip-off for us that some sort of fistulous communication is developed in the setting of acute cholecystitis. Case 4, we have a 72-year-old with acute onset of right upper quadrant pain, abdominal distension, and elevated LFTs. So we have the scout image from a CT scan, and then we have a coronal image from that same scan, and showing two major findings here. We can see pneumobilia, so in the scout image, and we can see also that there is a lot of retained contents, so within the stomach, indicating here that we have a gastric outlet obstruction. So the patient went on to have an MRCP. So MRCP demonstrates that we have dilation of the common duct. So maybe a little narrowing down here at the level of the lower common duct, but we don't see any filling defect to indicate that there's choledochilothiasis. So going and looking at our axial and our coronal haste images. So that demonstrates here we have this large, very hypointense round filling defect. Now this is actually in the second portion of the duodenum. We can see that here. And so that is the patient had the pneumobilia is related to the cholecystoduodenal fistula. So this is the stone which is dropped into the duodenum, and now it's inflamed and it's trapped at the level second portion of the duodenum. And that inflammation is causing narrowing of the common duct, and that's explaining the mild ductal dilatation. So this patient that went on 1 month later to have a CT scan. So initially was able to recover from the was treated and was recovering from the initial diagnosis. So the stone was left to pass, and then 1 month later, here we have a non-contrast CT scan. So demonstrating here is now the radiopaque stone. So it became trapped at the level of the distal ileum, and of course now this has gone on to become a gallstone ileus. So this is a migrated gallstone. Typically, it's going to be due to a cholecystoenteric fistula, passage of a stone into the bowel, and then usually there's going to be a bowel obstruction that occurs. It's some narrowing downstream. Most typically, we're going to find this in the ileum is going to be the most common place, but it can also happen within the duodenum pylorus. Imaging features that we're looking for the gallstone ileus is going to be a patient with unexplained pneumobilia, and then demonstration of an ectopic gallstone. And of course, a bowel obstruction associated with that. So ectopic gallstones can be difficult to visualize within the bowel lumen on CT. We will rely on the T2 haste sequences. So hopefully the fluid, we get good contrast resolution between the very hypointense ectopic stone and the fluid that's surrounding it within the bowel lumen. All right, so as a companion case, so this is a patient that developed a cholecystoduodenal fistula, so and had a gallstone that was then trapped in the duodenum. And so we can see here on the MRCP images, we have this extrinsic filling defect. This is going to be the filling defect, but this hypointense rounded structure here sitting adjacent to the common duct, producing a high-grade obstruction of the lower common duct and intrahepatic biliary ductal dilation. And this is a patient that had a cholecystoduodenal fistula. The stone passed into the duodenum, became lodged, and then due to the inflammation and mass effect associated with that, it went ahead and caused obstruction of the lower common duct. So just an example of Maritzi syndrome. We have an 81-year-old presents with diffuse abdominal pain, fever, and elevated white blood cell count, and an acute hemoglobin drop. So here we can see that there is a large amount of hemorrhage along the subhepatic space, along the caudal margin of the liver that's extending into the right pericolic gutter. But as we look at this here, so the image on the left is going to be an arterial phase image. Image on the right will be portal venous phase. We notice that there is this hyperdense focus. So that becomes a little bigger and a little less well-defined and kind of spreading out on a more delayed image. So this is a site of obviously, the patient is hemorrhaged with continuing active hemorrhage that we're able to detect as that hyper-enhancing focus. Patient went on to conventional angiography. So, and there's a small pseudoaneurysm that's developed of the cystic artery in this patient with acute cholecystitis. And then subselective, and when they went ahead and injected that, so we saw the blush at the pseudoaneurysm site, and it was an active extravasation that was occurring. So that a cystic artery pseudoaneurysm with acute cholecystitis is very rare, but it can occur, and it is associated with hemophilia and hemorrhagic cholecystitis. So what we expect to look for would be a pseudoaneurysm that we would encounter in other places, a small saccular outpouching with or without active extravasation of contrast at the time of imaging. So there's a quick look at some complications of acute cholecystitis. Now we're going to go ahead and look at some complications associated with cholecystectomy. So, of course, there's abscess. I'm not going to spend any time talking about that. It's something that we expect that can occur with any surgery, of course, that there could be abscess formation in the postoperative period. But also we can see bile duct injuries. So we would expect a biliary leak. There also can be misadventures with clip placement. So there could either be misidentification and something that was clipped that should not have been, or we can have a situation in which the clip was properly placed initially, but with time, due to movement and inflammation and other factors, that it can actually move over a period of time and then set up and create problems later on. And of course, there is a potential for vascular injuries. So that can occur with surgery. This is something that dealing with misidentification of structures, or maybe we have a limited field of view, various complicating factors when the surgery is going on. And of course, there can also be some visceral organ injury that's associated. So when we're looking at a patient, they may, with cross-sectional imaging that may be, that we know is maybe going on to having cholecystectomy, what we want to focus on is, it's called a hepatocystic triangle. You may see this also referred to in the surgical literature as Callot's triangle. So the hepatocystic triangle is going to be bordered by the cystic duct, the common hepatic duct, and the inferior margin of the liver. And the things that we will be mindful of here are the normal anatomic structures that reside in this space, and also any other confounding factors that might be going on due to the acute cholecystitis. So we want to make sure if there's variant anatomy that something is there or something is absent that should be there, that we want to comment that in our reports. So most commonly it's going to be variant biliary anatomy. So presence or absence of the inflammatory soft tissue thickening or hemorrhage in the hepatocystic triangle. I need to go back here for a second because that's related to the critical view of safety. So a critical view of safety is a surgical protocol that they use to address and to help decrease the risk for complications associated with cholecystectomy. In the critical view of safety protocol, the surgeon will go in, and the very first thing that the surgeon will do is clear the entire Callot's triangle or hepatocystic triangle of any fibrous tissue, any blood, any fat that's in the area. So the first step is going to be going ahead and getting a completely clear surgical view. Then at that point, mobilizing the neck of the gallbladder so that it's free from the surface of the liver, and then clearly identifying the cystic duct and the cystic artery so that everything is completely free and clear before then anything is done about attempting to clip or remove any of the structures related with the gallbladder removal. So we want to comment about any sort of fluid or hemorrhage or inflammatory tissue that may be extending to that hepatocystic triangle, and then also be aware of other variant anatomy that's at risk. So we can notice on MRCP, for instance, we may find a small aberrant duct that's running just below the capsule that could easily be injured and result in a bile leak in the postoperative period. And also the posterior division of the right hepatic duct. I'm sorry, this slide the animations are all kind of messed up here. So I'll just advance to the end and go ahead and talk through these. So some examples here. So on the slide on the left, so there's really nothing that terribly abnormal about this other than this patient has a particularly long cystic duct, and it is running, it's a long cystic duct and it's running very parallel to the common duct. So the potential problem that it creates there is that there may be confusion or misidentification of the cystic duct versus the common duct and could lead to a clip malplacement. So here we have the contracted gallbladder. We see the hypointense gallstone there in the fundus. And what do we notice here on this T2 weighted axial image? So we have ductal dilatation in the liver, but we also have this minor hepatic duct, so that is running just below the surface of the liver, right next to the surface of the gallbladder. It would be very easy, so either that to some sort of thermal injury or even transecting that as the gallbladder is being dissected off of the liver. And then here we have an example from an MRCP. Here's the posterior division of the right hepatic duct, having a very low insertion. So separately on the common duct, and we can see here, it's right adjacent to the insertion of the cystic duct. And having that there would make it be very easy. So for there to be an injury to that duct and result in, it could be clipped and cause a postoperative obstruction or injury to that duct and a postoperative bile leak. So moving on, we're looking at a couple more cases. A 57-year-old presents to the emergency department with persistent right upper quadrant pain 3 days after cholecystectomy. So I have a contrast enhanced CT. So it's demonstrating that we have fluid is here in the subhepatic space. In the coronal reconstruction, we can even see some of that fluid is beginning to track down into the paracolic gutter. So the image on the right is a HIDA scan. So we can see that there's normal uptake of the radionuclide by the liver with excretion into the bowel. But here we have this area of bile leakage here. That's where we see the radionuclide accumulating in the subhepatic space. So bile leak is going to be a serious complication and one of the more common complications that we will have to deal with in the postoperative period. You know, I'd say after, of course, like a postoperative infection. And so what we would look for there, so I think HIDA is the way that we've most that we're most used to. We've for a long time we've gone ahead and we've evaluated these. So, but other newer ways that, oh, excuse me, I thought there was going to be a little box that came up there. So that is MRI with EOVIST. So having a hepatobiliary phase. So doing delayed imaging, so looking for abnormal accumulation of the gadolinium in the subhepatic space was another tool that we have available to us. We have a 43-year-old presents with generalized abdominal pain 3 months after laparoscopic cholecystectomy. Laboratory values are significant for an elevated total bilirubin. So we have a coronal T2 haste image. So we see a susceptibility artifact here in the region of the subhepatic space. And that's going to be abutting this dilated common duct that we see. So, of course, susceptibility artifact coming from the cholecystectomy clips. And our MIP images from our MRCP, we see significant intrahepatic biliary ductal dilation and abrupt cutoff at the level of these ducts. So here, of course, was where misplacement of the cholecystectomy clips, in which instead of clipping the cystic duct, the common duct was instead clipped. So I find it pretty amazing that the patient was able to go 2 months before this was discovered. So a companion case, 58-year-old with history of cholecystectomy 2 years prior, now presents with acute right upper quadrant abdominal pain, elevated bilirubin. So this is an example here of clip migration. So on the coronal CT, we see the bright clip that shows up, and it's sitting here at the level of the lower common duct. We can see here in our MRCP MIP images, we have that linear filling defect in the lower common duct, and then upstream biliary ductal dilation. So this is clip migration can occur in patients who have that there's inflammation in the postoperative period and allows the clip to erode and then migrate. In this case, it actually entered into the biliary tree, producing a biliary obstruction. So case 9, we have a 50-year-old patient presents with elevated bilirubin 48 hours after, sorry, got ahead of myself. 48 hours after cholecystectomy. So we have a couple cine images here. So this is an arterial phase CT image. So we can see the cholecystectomy clips. And we have a surgical drain within the subhepatic space. So there's heterogeneous enhancement, kind of patchy wedge-shaped areas of hypoenhancement that we see starting kind of in the region of the periportal area and extending out into the periphery. So we notice here that on our CT images, just the close proximity of the cholecystectomy clips, so to the hepatic artery. And so here we have, this is going to be non-contrast, and this is going to be a portal venous phase image showing these wedge-shaped patchy areas of hypoenhancement on the post-contrast. So wedge-shaped areas of decreased enhancement that are radiating out from the central portion of the liver. And this is somebody who had a biliary ischemia secondary to hepatic artery injury. You got to recall that the bile ducts derive their blood supply exclusively, so from the hepatic artery. And if that's injured or ligated and clipped as a result of a cholecystectomy, so that can cause biliary ischemia, and that can manifest. Typically, we see here peripheral wedge-shaped areas of echogenicity or hypoattenuation on the CT scan that will result in the subacute period. So acute cholecystitis and can have a lot of troubling sequelae. So we need to keep an eye out for and be aware it's more severe forms, such as gangrenous cholecystitis or the life-threatening emphysematous cholecystitis. And we need to do our best to help our general surgeons and our hepatobiliary surgeons. If we know that the patients are going on to cholecystectomy, to bring to their attention any variants that we may detect on our imaging studies, and also bring to light any complicating factors such as hemorrhage or anything that may be producing abnormal mass effect or could obscure their field of view as they're going in and they're trying to identify structures. And with that, I thank you very much for your attention, and thank you for coming to the conference. Have a great day, folks. Thank you. Good job. Thanks. I don't want to do other people's lectures because they kind of, I did some editing and things like that.